The papillary thyroid neoplasms are more common in females. It occurs because of mutation in RAS, and translocations that result in fusion of RET or NTRK, causing activation of MAP kinase pathway. Ionizing radiation exposure is a risk factor. These tumors usually present as painless nodule or mass in neck or cervical node and are usually cold on scan. For diagnosis purposes, FNAC is done, which show typical nuclear features, nuclear overlapping, nuclear crowding, chromatin clearing, ground glass nuclei, nuclear grooves, nuclear pseudo inclusions, papillary clusters, and psammoma bodies. As I've shown here in this image with the broader arrow, pseudo inclusions in the nucleus, so it can be appreciated in FNAC of the papillary carcinomas of the thyroid gland. Also, this is another image of FNAC of papillary thyroid carcinoma, and you can appreciate with the red arrows I have depicted here the nuclear groups which can be appreciated in papillary thyroid carcinoma. Other features which can be seen in the FNAC are psammoma bodies and chewing gum colloid. This is a gross image of papillary thyroid carcinoma where you can appreciate the papillary projections. Here in this micrograph, I have shown the histopathology of papillary thyroid carcinoma, where you can see the arrangement of papilloid clusters of tumor cells. In these clusters, all the tumor cells are arranged around a papillae, as you can appreciate, and this is characteristic feature of papillary thyroid carcinoma and are found in classic papillary thyroid carcinoma. If you go to the high power, you can appreciate the nuclear features, and you can see here optically clear nuclei of the thyroid neoplasm, which are also known as orphan Annie nuclei, which is based on a cartoon character. Also, you can appreciate here and there nuclear grooves. Other features which you can appreciate on histopathology of papillary thyroid carcinoma are the sarcoma bodies and thick colloid. Talking about the variants of papillary thyroid carcinoma, classic variants include the papillary pattern. Other patterns are follicular pattern, cribriform modular pattern, diffuse sclerosing pattern, Worthen-like pattern, and solid patterns. You can also appreciate more than one pattern in one tumor. For example, papillary and follicular architecture both can frequently coexist within one tumor. Based on American Thyroid Association risk stratification, high risk papillary thyroid of carcinoma can be removed by total thyroidectomy and postoperative radioactive iodine ablation. Intermediate risk can be treated by subtotal or total thyroidectomy, followed by postoperative radioiodine therapy. And low risk, which includes intrathyroidal encapsulated follicular variant and papillary thyroid carcinoma devoid of aggressive features seen in intermediate or high risk groups, lobectomy will be sufficient. Very low risk, for example, papillary microcarcinoma, which are less than 1 centimeter without clinically evident metastasis, local invasion, or convincing cytological evidence of aggressive disease, active surveillance may be considered as an alternative for surgical approach.